Hello, and welcome to another edition of BNEWS In-Depth. I'm your host, Rich Hosford. This month we're taking an in-depth look at a problem facing many individuals and families across the country, the issue of addiction, with a focus on opioids. We're going to have two parts this month. Starting out first, we're going to speak with Lahey Health's Vice President of Addictions, Tracey Nicolosi, and in the second half, we'll be speaking with members of the Burlington Police Department about their initiative to help reach individuals suffering from addiction and offer them and their families the support they need. Let's begin with our talk with Tracey Nicolosi from Lahey Health. Well, if you wanted to learn about the science of addiction, I don't think you could do better than my current guest that I have here. We have Tracey Nicolosi, who is the Vice President of Addictions with Lahey Health. Tracey, thanks for joining us.
Thanks for having me.
So what I want to talk about starting off is just, it's an ever-evolving field. What is sort of like, how do the medical community kind of look at people suffering from addiction now as opposed to 10, 15, 20 years ago? How have things changed?
Present day, there's a much wider acceptance of addiction as being a chronic relapsing disease, and certainly for opioid use disorders in particular, there's a much wider acceptance of the stance that it really is a disease that can be managed in a similar way to other chronic diseases, but not cured.
And what does it say about who can become addicted?
I mean, pretty much anybody can become addicted. There are certain risk factors, as with other types of chronic diseases like obesity or diabetes or cancer, that could certainly increase the likelihood that someone develops a dependency to substances, but there isn't like a linear formula that helps us figure out who will or will not become addicted.
So the old kind of idea that there's a certain type of person who is, more likely or destined to become, an addict is incorrect.
Yes, I would say so.
However, there are certain types, certain risk factors that individuals may have.
Absolutely.
But so nothing about their character or anything like that.
No, and what's been nice about the broader acceptance of addiction as a chronic disease is that the idea that addiction is some sort of characterological defect really is no longer part of the thinking these days.
And as far as, what does that mean for patients or for people, potential patients? What's different now if they go in and say, listen, I have this issue than might have happened in the past?
What's different today is that the field is generally less likely to bring up the issues of morality and character flaws, and understanding that addiction really does affect the brain. And we know from various studies, from literature, that there are definitely certain parts of the brain that are affected when someone becomes addicted to any sort of substance. So for patients coming in, the stigma has decreased relatively significantly in Massachusetts, so that it's a little bit easier for folks to come forward and say that they need help. And
talk us through, so, I think people have an understanding that, somebody maybe gets a medication or they try a substance and it has an effect on them and they keep using it and it eventually boils into an addiction. But what is actually happening inside somebody's body or brain, as they sort of have that progression to becoming addicted to a substance?
Sure. So with opiates in particular, opiates go to a certain part of the brain called mu receptors. You're familiar with endorphins, which are the body's natural opiates. That's the place where the endorphins are. So we already have kind of pre-made areas for opiates to be able to gravitate towards. When folks generally start with, let's say, a prescription, they're taking it for pain. What ends up happening is that when someone over time uses increasing amounts of opiates, whether it's illicit opiates like heroin or fentanyl, or whether it's pharmaceutical opiates like an OxyContin, what happens is they develop tolerance. And with tolerance means that folks end up using more than what they originally intended to use.
Right.
So to get the desired effect, i.e. euphoria, they end up needing to take higher and higher doses. And when someone becomes tolerant, it means that there's now a physiological response, and it means that they're also dependent on a drug. If you take that drug away or that substance away,
Right.
now someone is going to go into withdrawal.
Yeah, and that was going to be my next question is what is going on inside of their brain when withdrawal is happening. Like, I know obviously I think people have an image of if they feel sick, they feel terrible. From what I hear of opioids, it's one of the most worst feelings that people can have. But what is chemically going on or physiologically going on?
So what happens when an individual goes through withdrawal, it's the body's way of basically trying to adjust at the fact that that substance, which someone has become dependent on, is no longer in their system. So the body starts to develop symptoms like excessive sweating. Someone's nose will start to run. Someone's hair on, let's say their arms, they'll experience what's called piloerection. There are definite physical changes that can be objectively measured and scored with regards to what's going on in someone's body.
So the brain is sort of like seeking the substance that's no longer there, and
exactly.
So it's not just it's not just oh, I'm not getting that euphoria feeling anymore. It's actually something worse than that.
It is. It's now something different, and depending on the primary substance that's being abused, that often determines what withdrawal might be like.
Okay. So it won't be the same for alcohol as it would be for opioids or cocaine or something. Other drugs have different types of withdrawal feelings.
Exactly.
And so right now, across the nation, we're talking about the opioid epidemic. What have you seen in your office over the past few years in regards to that?
What we've seen is certainly a significant increase in fentanyl showing up in the illicit drug flow. So that there's fentanyl now being found in heroin, it's being found in cocaine. Fentanyl is actually being manufactured to look like pills, so that when someone goes to purchase illicit substances, they may think that they're purchasing, let's say, a Percocet, when what they're really purchasing is fentanyl. And because fentanyl is so much stronger and more powerful than a Percocet or heroin, it's actually increased significantly the folks that are fatally overdosing. So when folks are coming into treatment, let's say in one of my inpatient detoxification programs, we're finding that they have a longer history of overdose, non-fatal overdose. We know that administering Narcan will save lives. We also know that with fentanyl coming into to play, that it's taking more and more doses of Narcan to be able to revive folks that are actively overdosing.
Right. So actually, just the one shot won't necessarily help because when you say that fentanyl is more powerful than heroin or OxyContin or something, it's not just like twice as much. I mean, we're talking magnitudes.
We're talking upwards of 50 times as much.
Right. I mean, it's so strange to think that somebody would try to hide that as they sell it. It's like, I guess it seems like they're just setting people up to overdose rather than continue. I know this is not your area, but it is such a strange phenomenon.
It is, and I mean, when folks are purchasing substances, they think that they're purchasing one thing, but what they're really getting is something else. And if you think about the laws of supply and demand, we tend to gravitate back towards products that we know work really well.
True. So
Yeah.
I guess you will get the level of high or whatever you need from the fentanyl. But let's back up. So before people get to the point where they're, trying to get fentanyl from, some person on the street, what are you seeing as far as people's path towards addiction? How are people that, are becoming addicted to opioids? What's sort of like some of the common ways that this is sort of, people are starting off?
A lot of individuals will actually start with a legitimate prescription for pain. And for one reason or another, they continue to get that prescription. And when the doctors determine that it's no longer necessary for them to continue with the medication, then folks that have now become dependent and have developed a tolerance, because withdrawal is so really miserable for folks, they're more likely to gravitate towards the street drugs.
And is there any talk or consideration about, controlling dosages or controlling prescriptions more, or is there a way of saying, like, obviously you don't want people in pain,
Right.
but how do doctors kind of approach that balance of, like, make sure the patient isn't suffering, but also hopefully don't put them down on a path towards addiction? What's kind of where are we at on that?
There's definitely been a change in prescribing practices where doctors have been more educated on the dangers of prescribing too many opioids. There are tools in place now. We have the prescription monitoring program, which is a database that physicians can now access to find out what someone's history for certain controlled substances might be. There are more widely accessible prescribing guidelines that have been published both on the federal level and on the state level, and obviously the wide, much better access to Narcan. Those are all tools that have certainly helped with regards to prescribing practices. And we know that in Massachusetts, the number of prescriptions for opioids has started to come down pretty significantly. So Massachusetts really can be considered a leader in combating the opioid epidemic.
Well, that's good to know. Anything for patients? I'm just thinking, like, you have a teenager or something, they get hurt on the playing field, need a surgery or anything, or you yourself need to go in for surgery. Are there ways, like, that you should talk to your doctor about or work out with your doctor, like, all right, well, we'll probably need it for this amount of time, or what kind of role can patients take in this interaction?
Patients really should have conversations about their doctor about the likelihood that they are going to be in pain post-surgery. And it's really a conversation with the physician where it's patients need to feel confident that their pain is going to be managed and taken care of. And doctors need to be able to talk to patients about what the options are. More and more, what we're finding are the more over-the-counter medications really are as effective, if not more effective, in some cases than the prescriptions for opioids.
And just a general question about addiction. We talked about some people are more likely to become addicted to something than others. Is it the case that somebody who's more likely to be addicted to one thing is also likely to form an addiction for another thing? For example, like, if you yourself know, like, okay, I've in the past had problems with drinking or smoking or something like that, I'm going in for surgery, I should probably make this clear to my doctor that I have a history of, or does it not correlate one to the other?
I think it's difficult for individuals that have some sort of history of addiction to actually talk to their physicians about that, because the concern is that when they are in pain, that pain isn't going to be taken care of.
Sure.
Yep. Having a problem with one substance doesn't automatically mean that somebody's going to have a problem with another substance. It's more about the cumulative effect of, genetically, is there some sort of predisposition in the family for substance use? What type of environment are folks living in? Kind of the nature versus nurture. We know that a significant number of folks that require treatment for substance use disorders also have a history of trauma.
Oh, really?
Yep.
So there's sort of something
Yep.
that having traumatic experience kind of makes you more susceptible.
It definitely can. I mean, that being said, we've also heard stories of people in families where there isn't any of that, and it's a very stable home environment. And, you know, for one reason or another, a kid gets a hold of a substance, and some very bad outcomes have ended up happening. So it's not necessarily a guarantee, but
Sure.
it is definitely, we pay much more attention when we're doing assessments for folks that are coming into treatment.
Yes. I mean, yeah, clear, because you hear stories of successful middle-aged people all of a sudden, you know, forming an addiction because
Yeah.
of, you know, post-surgery or
Yep.
something.
Yeah.
So what kind of, is there anything new or in the works or something that people are looking at as far as treatment? You know, I know that there's going to be programs. We're going to talk with the police department about, you know, what they're doing as far as that goes. But anything kind of interesting or new in the medical community about how to help people overcome these withdrawal symptoms?
So the gold standard for the treatment of opioid use disorder really is medication-assisted treatment. And at this point, we have 3 different medications that we can prescribe to folks that are struggling with opioid use disorders. The medication that is the most widely studied, that has been around for the longest period of time, is methadone. Methadone is very highly regulated, and it comes out of special clinics that have been licensed to be able to do that. For some folks, methadone ends up being the better medication to address the withdrawal. The other medication is buprenorphine, which is it's a little bit newer in terms of one of the medications in the toolbox. The other is injectable naltrexone, which is it's actually an injection that can be given once every 30 days. So given that we now have 3 medications in the toolbox, we're much better able to match the treatment to the person that is struggling with opioid use disorders. And I think the publicity and reinforcing that this really is the treatment of choice for folks that are struggling with opioid use disorders, I think that's new.
Okay.
Yeah.
So you kind of, but you said it's a combined therapy. So it's like you do the medicinal side, but then there's also going to be therapy and counseling, things like
Exactly.
that.
The medication is important, providing services and therapy to wrap around folks that are struggling with addiction is also an important part of what we do.
And is the duration that somebody would be using one of these just based on the individual, like how they personally kind of
It really is based on the individual. And for methadone and buprenorphine, oftentimes folks are maintained on those medications for a period of time.
Okay.
We know, like for methadone, if we are able to keep someone engaged in treatment for a year, maybe 2 years, that 90% of those folks will stop using illicit opiates.
Oh, that's a good percentage.
Yeah.
Now I know, you know, in addiction services and things, there's always, people always say there's no magic pill. You know, there's nothing you can take that kind of gets you to turn off that thing in your brain that makes you want that. But is there a quest for the magic pill? Is there anything that people are kind of seeing that, all right, maybe we can, you know, come up with newer medications or newer therapies or something that would make this sort of easier? What are you seeing as far as research?
There's definitely research into different types of medications to help with opioid use disorder. There's also research for alternative ways to treat pain that maybe are not, don't have narcotics in them. I think that the disease of addiction, it really does look like other types of chronic diseases in that, you know, someone who's been diagnosed with diabetes, you have the medication, you have insulin, and then you also have a recommended course of treatment that involves some lifestyle changes and maybe some counseling. So it's, with addiction, it's going to be really hard to find a magic pill that in isolation is really going to help someone manage the disease.
Okay.
Yeah.
Yeah. So it's a struggle for
It
people,
is.
but there's ways to make it easier for them.
Yes.
So I guess last couple things before, as we head toward the end of our conversation today. If somebody, sees this, or they know that they themselves have a problem, or a family member has a problem, what should they do? What is your advice as far as or not even advice necessarily, but how to get started on a treatment program? But also, I think there'd be a lot of fear among people. They know they've got this problem, but it is their comfort, it is what they do, it's their routine, and they know that by just showing up at the hospital or police station or somewhere else to ask for assistance, that it's going to mean some big life changes. But what would you say to people just to kind of push them to make that decision?
It's so people generally make change when there's a certain level of discomfort in what they're currently doing, and that's no longer working. So that's really what prompts folks to make change. We know that roughly across the country, only 10% of folks that struggle with substance use disorders actually access treatment. The stigma is definitely a barrier. Sometimes payment, insurance issues can be a barrier. The stronger support network that somebody has as they're beginning to think that maybe they do need some sort of treatment or assistance is going to be extremely helpful. There's the BSAS helpline, which will make available for folks the different types of treatment options that are out there. They could certainly speak with their primary care physicians. They could reach out directly to agencies like ourselves that provide different levels of care to help folks deal with and better manage their substance use disorder.
And then, so like you said, part of it is, I think the path to success is having that support necessary.
It's crucial.
So on the other side of things, if somebody watching this has a family member or a loved one or a friend even that they know is suffering from this, I imagine it can be heartbreaking, but also frustrating to see somebody relapse, time and time again. What would you say to them just to kind of bolster their sort of commitment to being supportive when maybe it seems like the patient themselves isn't really, trying, but they are, but, what are they going through that people should understand?
So for patients that are struggling with substance use disorders, there is an awareness that what they're doing it's not good for them, it's not healthy. Trying to figure out how to get treatment is sometimes difficult. When we accept the fact that addiction and substance use disorders really are chronic diseases, and we make that comparison, it lends itself to the same reason that, let's say, someone who was diagnosed with diabetes is having a really hard time getting their blood sugar out of control, and they keep coming back to the hospital. It's the same thing.
Right.
It's not as if that individual doesn't want help, doesn't want to get better. They just haven't been able to pull the resources together. And for families, it can be frustrating. It can be frustrating. The best type of treatment for substance use disorders really do involve families.
Right.
Once the individual is settled into treatment and is able to bring the family into the treatment.
All right. So to recap, addiction is a disease. It's nothing about the character of the person. Withdrawal is a difficult thing to overcome, and if you have somebody that you care about that's going through it, to be as supportive and patient as possible. And if you are suffering, then try to find the help that you need.
Yes. And make sure that they have Narcan.
Yes. I'll have a ready supply of Narcan, because you don't want to be without that in that desperate situation when you're trying to call 911, but the person's overdosing right in front of you. So yes, having Narcan available is just a good thing to do, especially with all this stuff out there. So that's all the questions I had. Any final thoughts? Anything I hadn't asked you about?
No, just thank you very much for giving us the opportunity to be able to talk.
We really appreciate you coming in. It's a difficult subject. It's an important subject, though, and I really appreciate you taking the time to come down and sharing your thoughts with our viewers.
Anytime. Happy to come back.
All right. Well, thank you very much.
Thank you.
One place where they have embraced the new science behind addiction and addiction recovery is here at the Burlington Police Department. They have partnered with the Police Assisted Addiction and Recovery Initiative, or PAARI program, in order to help better reach people suffering from addiction and their families. I spoke to Captain SKEHAN, who was instrumental in getting the program funded, along with Drug Unit Officer Robert ALOISI and PAARI Program Coordinator and Addiction Specialist Margie Taylor. Let's take a look. All right. I am now joined by three people who have been working for a little over a year now on the opioid program here in Burlington. I'm joined by Captain Greg SKEHAN, Margie Taylor from PAARI, and Officer Bob ALOISI. Thank you all for joining me, and welcome.
Thank you.
Thank you. Thank you for having us.
So can you talk about just kind of how this came about, this collaboration between PAARI, AmeriCorps, and the Burlington Police Department?
Yeah,
Maybe explain what PAARI is, too.
PAARI stands for Police Assisted Addiction Recovery Initiative. And about a year and a half ago, we tried to obtain some Narcan, and I got a contact to try and get some Narcan for the department, and that person told me, maybe you'd be interested in this organization. So I ran it by the chief, and he said, go for it, and that's how we involved Margie.
We put a team together in anticipation of bringing the PAARI program on board. Bob and I partnered. We brought together other resources to plan for it, to recruit people to our team, which was, we still have Margie Taylor with us now. She's been the program coordinator now even into our second year of PAARI, which is now regional. And we also have, we had one previous recovery coach, and now we have a second recovery coach. So that's the way it came about, and then we planned for it, put it into operation, put out a directive, and started rolling. So a little bit about the program.
Yeah.
Margie is the program coordinator now in the second year for a regional program. We are now joined by Wilmington and Woburn in a regional PAARI unit, and Margie oversees recovery coaches in Burlington, Wilmington, and Woburn, so 3 recovery coaches. And that's how we operate. We combine resources and information. But initially, this was just a Burlington program, and it was Margie and a young lady named Jackie Tiabi, who has now gone off to law school. And now we have Karen Shivo as our second recovery coach. So that's how that works. And it's we're very happy with it. We've had great success in the short time we've been running with it.
And what was the initial, sort of reason behind it, or the impetus to get this program or this collaboration going?
Yeah, no different in Burlington than all of the towns, surrounding towns. Virtually every community in this part of the country is really, really being impacted. They're all being impacted by the opioid crisis and other substance use disorders being endured by not only citizens, but anybody, visitors to our town, any guests to our town. This resource that it is, our PAARI program, is available for anyone within Burlington who comes to our attention. We're there to reach out and try to help these folks and the families that are also suffering because of loved ones dealing with some substance use disorder.
And Margie, what are some of the things that a recovery coach does, like on a day-to-day basis?
So on a day-to-day basis, it may look a little different depending on what demographic you're in. We have peers that are in Lynn, for instance, and so their day-to-day may look a little different than Burlington just because of the difference of the way the towns and cities are made up. But on a day-to-day, it would be me checking in with people I've been working with, whether they're doing well or not well. It may be responding to overdose calls that come in to the police department with Bob and offering resources right there in like a live time, checking in with families and offering support services for them. And then also making the relationships within town with the different agencies, whether it's the school department or the Department of Public Health, fire department, so that they know the resources there and we can all partner together to help everybody involved in the community, because it's it's not a, you know, one size fits all issue, and so you need to have those relationships to help the community, you know, as a whole.
So it seems like a big part of it is sort of like public education and public outreach, kind of get the
Absolutely.
word out.
Absolutely.
How have you found that, you know, as you're trying to work with different organizations in town, the response from them as far as, you know, their interest level in working with you on this?
They're very, very willing to cooperate. Everyone understands it and how bad this is, and we're just trying to save lives and help the families that need the help.
Yeah, I'd say more than overwhelmingly positive. I don't think we've really we've yet to meet anybody who's been negative about the program. I think we're fortunate in that folks are realizing now that it's a very big social issue. It's a family issue, and you know, there's just so many people impacted. So it's been fabulous. We haven't even had to deal with any negative feedback at all. Everybody is very encouraged and thankful we have this program to help.
Yeah, excellent. And just sort of talk in general for people who maybe, you know, they know that obviously there's a national opioid crisis, but maybe don't really feel its impact locally. What do you see as far as just in Burlington and surrounding towns as sort of like, you know, the level of the issue or the problem, I guess?
I think it's still pretty serious around here. A lot of the shoplifting calls we have are people who are trying to feed their addiction. We have, I would say we average an overdose a week, maybe every other week.
Mm-hmm.
So it's still pretty strong. It's hard. It's hard for the user.
And it's hard to put a number on it because of the access to Narcan. Maybe the calls coming in to EMS aren't as high as they used to be. So we only know about the overdoses that are happening within town that are going through the 911 system.
Right.
So that doesn't mean that there's not Burlington residents overdosing in other towns that maybe we just don't have a relationship with, that we're kind of hearing about it. And also if the person's been struggling for quite some time and their family's educated on Narcan and has it in the house, it may be somebody at the home that's Narcanning them and they don't actually end up calling 911. So, you know, those are the calls that are coming in general, whether it's one a week or every other week ballpark. But, you know, the issue is greater than that, and you can only kind of base it on the calls that you're receiving.
And just want to talk about, because, you know, I don't know where we all are, but I was a child in the 80s, and we definitely had, you know, the war on drugs was in full swing, and a lot of the images that you'd get of the drug dealer was very stereotypical, you know. It was like the guy on the street, lifetime of crime and bad decisions. But talk about the truth behind some, you know, a lot of people who find themselves addicted to these substances.
I mean, honestly, there's no one face. And so the stigma that it's somebody that's not willing to work and is homeless and maybe unkept is the reason why a lot of people don't ask for help, is because of that stigma. I'm in recovery myself, and I have a job, I go to work every day, I have a college education, but for me it was an athletic injury. You know, I wasn't somebody that, you know, you might have seen on the war on drugs or was just partying. It was life circumstances that happened and a long line of prescription painkillers that were given by a physician. So it's not just young kids in middle school or high school that are out partying that develop a habit. It could be somebody that's been on long-term pain management from a car accident, or somebody that was maybe having long-term treatment for cancer and got addicted to opiates. And the issue is there's not a lot of transition from being on the medication to how to safely get off it. And so when a person is faced with, okay, I don't think I need this medicine any longer, let me just come off of it, they get viciously sick with withdrawal symptoms. And so there needs to be a bridge for that. But it's a family disease, and it could be mom and dad at home that a child from the high school is going home to that's struggling with alcoholism or opiate addiction. It doesn't have to be this young partier or somebody that doesn't take care of themselves. And that's what people need to understand, is that it touches everybody. And if it's not happening in your house, it may be the neighbor next door or the mom down the street. It doesn't have one face.
Right. Absolutely. And, you know, if you ask anybody, chances are, if you were to randomly poll people, they know somebody maybe in their family or a family member related to a friend of theirs that is suffering or was suffering because of substance use disorders. We're getting, the problem is so big, I think it's more on the level of alcohol. What does someone who is abusing alcohol look like? Well, it's all walks of life and all ages, as Margie said. It's very similar to that. There's no question. There is no face. It's all faces, and we see people from all walks of life, of all ages, reaching out to us, and we've been able to help some of them. And thanks to these two here and the work they're doing on the street every day. So.
A couple of things that you said that I kind of want to respond to. One, you mentioned the words, the stigma behind it. I know that, there's been other, pushes by local organizations in town that were focused on that. Talk about that, the importance of trying to let people know who are possibly, who are suffering, that, that sort of societal pressure to keep it secret is kind of dissipating. Would you say that it is, and does it need to? I'm guessing it does.
I think that keeps a lot of people from asking for help, especially in a smaller community like Burlington, and it's a little bit more close knit. There are people that don't want everybody to know their business, and there's a lot of shame and guilt that goes along with this disease and what it does to the person that's struggling personally as well as their family. And it's very hard to ask for help in general, never mind on a sensitive kind of subject like this. And so a lot of people feel alone. They know there may be an issue, but to open up to somebody that may not get it, it's safer for them to keep a wall up, because people do have preconceived notions and ideas of what this looks like. So you may not always get a warm response, and that does keep people from asking for help. But in the meantime, we're losing a whole generation of people to the opioid crisis. And so what we like to provide is that it's confidential, and people can call me directly if you're not comfortable, say, going through the police department, or, your child's been struggling for a while. We want to provide that lifeline, that it's confidential and safe, and that not everybody does need to know, and that we're going to provide a service to help you get the help you need. But that everybody's touched by this issue. And so like we said, whether it's happening in your house or not, you probably have a family member that's struggling, or a neighbor, or a child, at school that's a friend of yours. We want people to ask for help, but ultimately that has to come from within. But what can help is a more understanding community, and that it touches the community as a whole. And
so what are some of the ways that people, get in touch with you or come to you? Is it a combination of, people finally realizing they've had too much, family members? Is it when you have to, when there is a 911 call? What are some of the ways in which you kind of, get people to, in touch with people?
I mean, like you said, there's a variety of ways. Sometimes it's a 911 call that comes in, and it's Bob and I responding, and it may be, some people that Bob just knows from being out in the community and on the police, force, that has had struggles in the past, and maybe we just develop a relationship to check in. My information is on the town website as well as the police website, so it's available there. And then a lot of it is just doing outreach and building those connections. So it's meeting with, staff at Lahey and developing a relationship with the ER department there. And the different houses of worship within town have been super supportive, and speaking at, Mass on Sunday, or going to worship events during the holiday season. Meeting with the fire department. I've made it a point to kind of get my face out there and hit the ground running, because people can't access it if they don't know it exists. So that has been important. And also going outside the town barriers and speaking at support meetings for, say, family members. So the calls do come in a lot of different ways, and a lot of times it's word of mouth. It may be that I've met one parent whose child's struggling, and they pass my card along to the next, and then it's just like a domino effect of it touches a lot of hands.
And now, from a policing perspective, what's the kind of the philosophy about, somebody, let's say, someone's child is using, obviously, but maybe they have a concern that, like, oh, well, but if I get in touch with the police, they might get arrested for possession of these, illegal substances. is the focus more on arrest, or is it more in trying to channel people to this program or other recovery? Like what's the police response now?
Well, our philosophy on the department, as you're going to find, is very similar to a lot of departments now, because what we've seen is a change in the philosophy in the policing profession as a whole. You know, for the most part, with very few exceptions, police have come to realize that we need to do more than just make arrests in order to combat the opioid crisis, and not just opioids. We like to say substance use disorders because it's not always just opioids. This unit is dedicated to any substance use disorders. So we've seen that, and I think that change has come pretty easily. I think this was not a tough sell, really, compared to some shifts in policing throughout the decades, because the scope and size of the problem. So police will still enforce, we will still enforce drug laws. We don't want people trafficking drugs, but we realize there's also a great population of people who are suffering because they have a substance use disorder. And as Margie said, it can come, and you can arrive, folks can arrive at that stage because through a variety of situations, one of which is people, and a lot of times young folks, getting addicted to painkillers that have been prescribed by doctors, and then they get hooked on these, and they've got a real problem on their hands. And that's just one example. So we know that by putting the two together, we're still doing what we've always done as far as drug trafficking and people pushing drugs on our street, but we also realize that arrest will have very, very little impact on helping all the folks who are coping with these substance use disorders. And then a very important component is to talk about the families who suffer with loved ones. As anyone can imagine, we all have families. Anyone in your family who's suffering through this, you're all suffering because we care about each other. And beyond that, care about people in our community. So, yeah, we knew that we had to do more, and I think overwhelmingly you're seeing more police departments do more. And I think that the unit that we have, the PAARI unit, it's still fairly in its early stages. I foresee a lot more departments will be coming on board and initiating some type of unit like this. And I know that PAARI is hoping to, again, they're taking on new departments all the time. So it's a good thing. It's great news. The sad news is this is a crisis that's big, and it's not going to be an easy fix.
No, absolutely not. And we'll get to some of the successes that you've seen shortly, but a couple more aspects about the issue that I want to kind of talk about. So you talked about, people get addicted through prescriptions, but what kind of, beyond just what people are prescribed, what are you seeing as far as different types of, opioids or other drugs that people are using maybe after their prescriptions are over?
The problem is people think they are using heroin, and it's not heroin anymore. It's heavily dosed with fentanyl, and that is what's just too strong for a lot of people. A lot of people go to rehab, they come out and they use, and they think they can use what they've always used, and it's way too powerful, and that's how we end up with an overdose. But the people who are selling this stuff, they don't always know what they're selling.
Yeah.
And so the user doesn't know what they're taking, and it's just a big problem. They press them into pills to make them look like Percocets, and it's just all fentanyl. So I would just let everyone know that you don't know what you're taking.
Yeah, I've seen those, they show the picture of a dime and then a small little bit of powder, and it's like that's enough to, kill somebody with some of these new sort of synthetically made. Yeah. So is the issue that, people are on a prescription that runs out, and then they just, rather than trying to get more, they go to the street or the illegal substance, or find it illegally, but then, like you said, they don't know exactly what it is.
Exactly it. Yeah, the prescription runs out, the doctor won't renew it anymore. Then they try and buy maybe the pills on the street, and after the pills get to be too expensive, they escalate to heroin, fentanyl type thing.
So do you think that there needs to be something at that level, like for people at the end of their prescriptions, like change in the policy of medical profession? Maybe this
That is changing.
Yeah.
I think it is. There's doctors, and again, Margie can speak to this better than I can, but I know that there's a push to train physicians about the dangers and about overprescribing. And my understanding was, there might have been some training, but I have heard, and I've no different than anyone else in the news, that there is, a push for that and plans to give doctors a higher level of training, or anybody who prescribes, as to the impacts, and Margie can maybe expound upon that a little bit.
Yeah, so I mean, part of the problem is, whether it was from surgery or somebody that was, receiving treatment that was painful, whatever the process is, there needs to be a kind of a bridge at the end where you're not on this high dose of medication that you've been on for months. I mean, at some point, you've been on a medication for so long, your body gets so used to it and dependent on it, say like food or water. Now, if you were to rip that away from somebody very abruptly, they're gonna have a reaction. And that's what happens with the prescription pain medication. So they're on it so consistently for such a long period of time. When you just stop that and you don't refill a prescription, it sends somebody into instant withdrawal. And it's miserable. It feels like the flu times 100. It's not anything anybody ever wants to experience. And the only way to make those poor feelings go away is to put another opiate in your body. And that's when you're seeing somebody go into the street and buying it, whether it's the pills or the fentanyl or heroin. There needs to be a gap where you're slowly weaned off the medication so that you don't have this 100-pound, ton of bricks thrown at you when your body reacts to zero medicine. You need to slowly wean down off of it so that the person has time to adapt and their body can slowly adapt to having no medication in their body, and that's what's not happening. So you're getting a medication for a long period of time. The doctor says, you know what, I think you're becoming dependent on it. I don't think you need it anymore. That's it. And the person is just left from a very high dose to none. And it's just, it's terrible. And that's when people are turning to the street, and because that's the first thing that's going to make them feel better is putting that medication back in their body.
I believe the doctors are also prescribing less, like you said with the 80s. You got 30 Percocets and you had your wisdom teeth pulled. I don't think that's
Right.
the case anymore. It's just a few to get you through a couple of days. And that's teenage level kids, they're going to get addicted quicker.
Yeah, that's a lot. So if somebody, comes to you, or their family finally gets them in there, what do you do? Like, what is the process that you engage with people? And I'm guessing it's somewhat individualized, but kind of in general, what are some of the things that help get person from the depth of addiction to road to recovery?
And it does look different for every person because not everybody wants the help at that time. So if I had somebody that was looking for help that actively wanted to get better, we would figure out kind of where they are in the process. And if they're still using or very newly not using, maybe detox is an option that's needed for safety for them as far as withdrawal symptoms and depending on what type of medications they're abusing. So it may be detox and then an inpatient program for a month or so, and then maybe sober living after. Maybe it's an outpatient program that they go to several hours a day and also go to work, or a 12-step program like AA or NA. The important thing is to not shove any treatment down their throat and kind of have that active listening ear as to what they're willing to do also. Because what I may think is going to be helpful, they may not be willing to do, and so we need to kind of meet people where they're at and find a plan that's successful where they're a part of the topic of conversation as well. And so what are they willing to do, and from my experience, what do I think will be helpful, and then devise a long-term plan from there, step by step, to get them into recovery. And if they're not looking for help, it may be working with the family. And so maybe that person's not ready for help yet, and they're just resistant, and that's me giving them my information and letting them know I'm here when they're ready. But working with the family, and what does the family need for support? And a lot of times that's getting them support resources to work with other families of those that have suffered or are suffering from substance use disorder. because that relatability of one parent knowing exactly what another one is going through, you can build that relationship and, devise a healthier and happier home for whoever's left at the house. Because there may be other children at home and parents, and, they need to have a stable environment as well. So it really depends on the person and what they're willing to do, but we can work around that and work with them to get them the resources that are necessary to get them on a better track.
And, like we said, it's been over a year since you've done this. So I always wanted to get into some of the, things that you've been able to accomplish. Before that, though, I did want to touch base real quick. We talked about Narcan in sort of general, but talk about what it is, what people need to know about it, and I know you've offered a couple training sessions about it. Mm-hmm. So just sort of get people caught up to speed about, Narcan and how it works.
So usually when you've overdosed on medication, you're unconscious, Narcan or naloxone is what's given to kind of reverse the effects of the opiate that you've taken. So it kind of removes the opiate from a certain part of your brain so that you're no longer under the effects of that medication. However, what people don't realize, it only has about a half an hour window of half-life. So within a half an hour, you go back under the effects of that opiate, which is why several doses are usually needed and why usually you go to the ER to be monitored. It's important for people to know how to use it and how to access it. Anybody can get it at your local pharmacy. If you don't have insurance, unfortunately the price has gone up quite a bit. I think it's about $150 for a dose. If you have insurance, usually it's whatever your co-payment is on your insurance, but anybody can go to Walgreens or CVS and request it to have it in the home. If you don't know how to use it, you can go to your Department of Public Health, you can reach out to me, or there's always trainings going on on how to administer it and a little bit more in-depth information on it. But it's a drug that's really saving a lot of lives. Unfortunately, with the potency of fentanyl, you need several doses typically for it to start kicking in. But if you've called 911 and you're able to give a dose of Narcan on your own, you've given that person a lot better chance of surviving because you've already administered the medication while the fire department's, en route.
Right.
Narcan's a lot like the AED or an EpiPen, something you can just apply immediately and save that life real quick, and then you have to follow up. If you give someone a defibrillator shock, you don't just walk away. They have to do something. Well, someone who's been Narcaned, it's just a Band-Aid. They need to follow up with her or with meetings and treatment. It's just you were gone and now you're back and now you gotta recover.
Right.
Yeah.
And it's important to note, people need to know, first responders carry Narcan. All our officers carry Narcan, so we are using that to good effect, and we've had great success with that. But what has been really encouraging is through the Narcan training of the public, through what Bob and Margie have done with the recovery coaches, as I mentioned, formerly Jackie and now Karen. They're training folks at home. Anybody who wants to come to the training to use it. And we, upon some trainings, we saw immediate success. There were 2 saves. There was one in Burlington and then one with a Burlington or a resident. I don't remember if it was a Burlington resident, but this person was in Boston. I recognized the effects of an overdose and used that very Narcan that this person received at the training to save someone in Boston. So it is encouraging. It's a miracle drug for those situations. But as Bob said, it's just a quick fix. But nevertheless, a very important one, because otherwise these people would not make it. They would probably succumb to their overdose. But with it, it's simple to use. But as Bob said, you've got a lot going on there, and there needs to be follow-up. That's why when we have it, we strongly encourage folks to go down to the hospital even after we administer Narcan. The dangerous situations are the ones that Margie mentioned, where people might be administering Narcan and we don't even know about it.
Right.
And with that also presents the problem that we don't have our resources, i.e. the PAARI unit, to come to bear on the problem with outreach to help these folks. Just Narcan alone, and there's a good chance that person's going to use again. And so that's why if we know about it, at least we got a chance to reach out to these folks, let them know there are resources available. they're not alone in their suffering, that there's a lot of folks going through the same thing they are, and if we can in any way help them, we're there for them. That's the message we're trying to get out to folks every single day with this PAARI unit. PAARI AmeriCorps unit, I should say, that's the full name of it, with funding from another grant. We can talk about that after if you'd like.
Yeah, well, so you mentioned, for just from the Narcan training, the 2 saves, a lot of this, obviously, being anonymous, working with people in, difficult situations in their lives, it's not going to be headline success, so to speak, where you get to sort of say, give out these numbers, oh, we did this and this. But one example that kind of came up recently was a letter that Chief Michael Kent received that he read at a Board of Selectmen meeting that he sent on to me, that I just wanted to let people know about. So this is, one of those examples of at least one individual who, worked with PAARI and worked with the 2 of you and, made a big difference in her life. She writes, and again, anonymously, I am writing regarding Margie Taylor, Jackie Tiabi, who was the other coach, and Bob ALOISI. It was a year ago tonight that I attended my first of many Burlington Overcoming Addiction meetings. Out of desperation and feeling like I had nowhere to turn, I reached out to Bob, who met me in the parking lot of St. Mark's Church, so I didn't have to walk in alone, as I was very nervous. My soon-to-be ex-husband was abusing opioids, and my living situation was growing darker by the day. I have 2 children. It was not just me at home. I left that first meeting with many resources, support, courage, and found that I am not alone, which was everything at the time. Within 2 days, she writes, Margie and Bob helped me find the husband a bed to detox, and after that a longer-term sober house. It was by the grace of God that this program and these individuals were there when I needed them, and not only saved my life but also his. So just sort of talk about that as the reasoning or the reason for this program, and what are the other types of examples that you've heard from people.
Well, she showed up that night, and I don't know how many people were there that night, but she was floored by the number of people that were in the same boat that she was. And I don't know if that made her feel better or just allowed her to go to the next step. Mm-hmm. She wasn't alone. Like she said, she wasn't alone. And there was people there in the exact same situation she had. And that person was further along and was able to give her some advice. And it worked out well. In this case.
Yeah.
That letter there is an example. If that was the only success of our PAARI AmeriCorps unit, it would be worth it to know that we saved one person's life. But we know that we've had a positive impact on many, many more people. It's just that that's what makes that letter special. Not always is somebody going to articulate all of that in a letter, but we appreciate hearing that and knowing that our unit is making a difference. It's very rewarding. It makes it all worthwhile, without a doubt.
Yeah, I mean, I think for her, like Bob touched upon, there was a sense of comfort when she walked in that room to see other people there that could 100% relate and give her advice on what she was going through. So she didn't feel alone. And at one point she did mention that I thought it was the only one. Mm-hmm. And so to walk in and be able to talk to another wife or a mom that could relate that had dealt with a child that was struggling, there was an instant connection and comfort level that was built. And, she wasn't at home. And so it didn't just affect her, and it affected her household like we kind of talked about earlier, and her children. And it had been going on for several years. It wasn't a new issue, but it was getting to the point where things were just continuing to go rapidly downhill. And it was a joint effort of, making phone calls and her husband also being willing to get the treatment, and he's doing well, and their family is in a point of repair, and maybe this, relationship changes, but he's an active father and he's able to show up and be there, and he's working, and, he's leading a productive life. And at one point he wasn't. And she was able to show up and reach out to Bob, and we were able to help her along the path, and it wasn't easy, but he continues to do well. And this was, I think the night before Thanksgiving, so a little over a year ago, and he's still doing well, and their family is in such a better place.
And I think that letter is an excellent example of what we talked about earlier. It's not just the husband's life. He's the one, as you read in the letter, that is suffering from the substance use disorder, but it's it's as much equally the wife's and wife and mother of the children, her life and the children, maybe most importantly, the children.
Mm-hmm.
So we know right there in one family, that's in the immediate family, multiple people being affected equally. And then the extended family, I would imagine in our letter we talk about the immediate family circle, but I'm sure there's extended family that were also suffering, concerned about what's going on in the family. So it really does touch, you see how many lives that one person with a substance use disorder can impact. That disorder, it can impact many, many people's lives. That's the reality.
Sure. I mean, the husband had other relatives besides his wife and kids, I'm sure.
Right.
Yeah.
It's just a rippling effect.
And I think when we talk about the stigma, a lot of times it goes directly to people that maybe aren't taking care of themselves or are living, somewhat of a criminal lifestyle or on the street, or young adults. And this is a case where it's not this person in high school or in their mid or young 20s that are suffering. And this is a dad and a husband, and, those children are going home to school and having to cope with a home environment that may not be quite up to par. And so that's the idea of where people need to realize that it doesn't have this stereotypical face that people, associate with addiction. And this was, a person in their mid-40s and at home and trying to take care of his family, and he was suffering. And so that's what people need to understand, that it goes way past what people think are going on, and it doesn't have a face.
Very good. Now, as we're looking to wrap, if somebody is in a similar situation where they themselves or a family member is suffering from addiction, what are some of the ways they can get in touch with you? Where can they go? I mean, the letter mentioned St. Mark's and Burlington Overcoming Addiction. Talk about when the meetings are.
So the meetings were put on hold, just more of a transition kind of period where, I'm still here, but now it's a regional approach, and also we are waiting to get a new recovery coach in. Part of one of our struggles is letting people know that those meetings existed. So, having a better attendance level. They were typically on Wednesdays, and I think we're just in a period of trying to figure out how to reschedule them so that there can be weekly attendance as far as on, my behalf or Bob's. But as far as getting in touch with us, you can always call the police station directly. I have my own landline there. My information is on the town website, as well as also the police website. I have a work cell phone that people can contact. There's a lot of different ways. You can reach out to the different faiths in town. I've met with all of them individually as well. But you don't necessarily have to meet me at the police station, and I'm happy to meet you wherever you feel comfortable and safe. And so maybe the police department isn't that place for you, and maybe it's at, a coffee shop or a bookstore or something. The idea is for somebody to feel safe where the information is kept confidential, but where they feel like they're in an environment where they can share and be honest so that we can get them the proper help they need.
Do you have a direct your line on the website?
Yes.
Okay.
Okay. Got a direct line. One thing I didn't want to miss this opportunity, since we're talking about this unit, there is thanks that I feel obligated to give. First of all, we're very thankful to PAARI that we have this unit. And then the funding sources. AmeriCorps funds many PAARI units. In addition to that, though, the reason why we were able to take this regional is we also got a grant from the Cummings Foundation, and we're very grateful to them. Burlington Police also, we've got our own Cummings grant for a mental health initiative that is now rolling. That's all mental health issues. But PAARI, Burlington Police Department, we worked with PAARI to help them get this grant from Cummings. So with that $100,000 grant from Cummings, and that's part of the $100,000 for 100 communities. That was one. PAARI received one. Burlington received a separate one. But that allowed us to extend this program to a regional unit instead of just Burlington. Now we're the three towns, and for 2 years instead of one. So we are the Cummings Foundation is a wonderful organization. Mr. and Mrs. Cummings are just great people, and they're doing a lot of good in communities, and wanted to thank them. And then all the funding from AmeriCorps. There's a lot of great things happening through funding through AmeriCorps as well. And we wouldn't be able to do it without those funding sources. Or should I? Let me rephrase that. Maybe Burlington could do it, but it is a significant amount of money.
Right.
And so that's something that needs to be recognized.
Can I add?
Yep.
Anybody can call the police station and ask for me. People know me. They can reach out to me. I will have no judgment whatsoever, and I'll pass them on to Margie. I'll deal with them myself. Also, as Captain SKEHAN mentioned earlier, there is another side of this, and we will take any information people have. We have an anonymous tip line. It's 781-505-1111. If you think something's going on that we should know about, you can call that. Not leave any information about yourself, and just tell us what's going on. But we have all these avenues that we can help people with.
All right. Very good. So 781-505-1111.
Yep.
And then that could be an anonymous tip that, see something, say something kind of thing.
Yeah.
All right, very good. Well, I'd like to thank you all for coming in.
Thank you.
Thank you.
Captain SKEHAN, Margie Taylor, Bob ALOISI, Officer ALOISI. Appreciate you coming in, sharing, information about this program and letting people know that, the resources are out there if they need them. Appreciate it.
Thank you.
Thank you.
Thank you.
All right.
So there you have it. I look at the science behind addiction and what local organizations, including the Burlington Police Department, are doing to address it and to reach out and offer support to those suffering and their families. It's an important topic and one I hope will reach many people with the strong message that if you or a loved one are suffering from addiction, help is out there. For BNews in Depth, I'm your host, BNews Director Rich Hosford, and we will see you next time.